All right, Bryan Heiderscheit, welcome to the Informed Performance Podcast.
Hey, Dylan, thanks for the invitation. Looking forward to it.
Right on. Well, you certainly have quite the background with a multitude of different experiences and ways in which you've kind of gone about your professional career. And so, if anybody has not heard about you yet or isn't familiar with who you are and what you do, please take the time and just sort of introduce yourself to the listeners, and then we can get things started.
Sure, happy to. So, as you mentioned, I've been in the field for quite a while. Actually, I just realized it's been 30 years this year, so it's been a haul. It's been in a variety of roles. First year out of school, worked in private practice a bit on the West Coast, actually in your neck of the woods out in Oregon, down in Southern Oregon, for about a year. And then I ended up going back pretty quickly for my PhD. I always knew that was an area of interest, the research side of it. So then jumped coasts over to Massachusetts, where I did my PhD in Amherst. And then made my way back toward the Midwest, which is where I'm originally from, in the state of Wisconsin. And I've been on faculty at Wisconsin for a number of years since. So I'm currently a professor and vice chair in the Department of Orthopedic Surgery here at UW, the director of Badger Athletic Performance Program, which is a collaborative venture between orthopedics and UW Athletics, where we test all the student athletes on campus in a variety of different ways for purpose of both performance as well as injury risk mitigation. And then I've been in clinic practice pretty much since day one, even during my PhD training and onward. Always having at least a day or a day and a half of clinic practice, focusing primarily on sports related injuries and even more recently, well, I shouldn't say more recently, even more specifically on running related injuries. Uh, yeah, that's kind of where it's been at. So I've tried to keep a foot in a variety of different pots, between clinic research as well as some level of teaching.
That's awesome. Whereabouts in Southern Oregon were you?
Down in Ashland, Medford area. Yeah.
Awesome. Yeah, I spent 3 months about like this last year down in Ashland. So it's a fun spot. It's plenty of fun characters to chat with and different from the rest, but that's kind of Oregon in general. So I dig it.
Right. Yeah, exactly. No, I love my time out there. I mean, it was short spent just in terms of changing coasts, but yeah, I absolutely loved it. A lot of fond memories.
Awesome. Well, today the conversation will largely be centered around the idea of hamstring strain injuries and hamstring injuries in general. And I think a good place for us to kick off is just asking, why do hamstring strains occur in the first place, or how do they occur?
Yeah, I mean, hamstring strains are definitely an area that we've done a lot of work in over the years. I didn't really get into hamstring injuries much until I arrived here at Wisconsin, and that was with a few collaborators. Started to do some of the early work because what we realized is even though these injuries are happening, there's not a lot of active science going into hamstring injuries at that time. Again, this is you got to put your historical lens on. This is 20 years ago, and in the U.S. especially, not a lot of work being done. I mean, if you look at the majority of published papers in muscle tendon, muscle injuries, muscle strain injuries, a lot of it's done internationally. So we had a bit of catch up work to do. And in particular, our strength is obviously in the biomechanical area. So we want to just understand the context in which these injuries were happening, right? We know that they happen a lot during sprinting or during a lot of high speed running related tasks. And we know they happen a fair amount in kicking. So let's understand the biomechanical circumstances under which these are likely to happen. And so we ended up focusing on sprinting. As I mentioned, my area has historically been running injuries, and so this falls under that umbrella. But studying sprinting injuries is a whole lot different than studying distance running injuries, right? I mean, the data acquisition challenges are quite unique for sprinting. It's hard to put somebody on a treadmill and say, all right, run as fast as you possibly can. We did that. We actually had people run 21, 22 miles an hour on a treadmill. Thankfully, nobody sustained a hamstring injury during the process, but it was quite an event. But what it allowed us to do was biomechanically characterize the loads and the mechanics of the hamstrings during high speed running. So we could have individuals run at their peak sprinting speed as well as at 95% of it, 90% of it, 85, 80% to get a sense of how things changed on the hamstring muscles, as well as were there any unique differences between each of those muscles. Now, again, in order for us to look at individual muscle effects, we're having to use computational modeling to do that, right? It'd be one thing if we could strap buccal transducers on each of those muscles, but of course that's going to be frowned upon by just about every IRB in the world, especially in healthy individuals. So that's not an option. So we had to obviously go by what we could do from a computational standpoint and estimate, and that's really what it is. They're estimates. The estimates are only as good as the model that you use. And so that's a part of it as well, as we needed to make sure we had as rigorous of a model as we could at that time, that would allow us to get some good insights, at least into what sort of influences speed, for example, had on some of these hamstring related loads.
I love that. Are there any kind of known risk factors currently associated with sprint related hamstring injury?
I'd say the best risk factors that we have, and they're not very good even, would be age. And that is, the older you are, the more likely you have to experience a hamstring injury. And then prior hamstring injury, right? I mean, that's always the one that always creeps up. Prior injury of a particular injury sets you up for greater reoccurrence of that said injury. But if you look at other factors like strength, flexibility, hydration, training load, you need to start to tick them all off. That they haven't been eliminated as risk factors, but they also haven't been very well supported as risk factors. One that's gotten a lot of attention over recent years has been eccentric hamstring strength. In fact, there's products and there's devices to test this and screen for it. And I would agree that clearly strength plays a role. If you're too weak, you're going to be at risk. But generally speaking, from a screening standpoint, you just need a bare minimum of strength in order to be actually not or any longer at risk, at least as far as the screening dictates. Then it becomes more of an individual athlete level. So the idea of saying what's a risk factor versus what is a screening tool that we can use to identify those at risk, those end up being two different kind of categories to some extent. That's actually a project that we're trying to do right now. We have funding from the NFL through one of their funding mechanisms to study hamstring strain injuries in the NCAA collegiate population. And so we have 5 different universities that we've been collecting data on for the past 3 years, their football programs, to better understand what these risk factors are. Hopefully, this will be one of those studies that has enough size and enough power that we can really start to better answer some of these questions.
Yeah, I really like that topic on like, the difference between a screen versus a risk factor because I think a classic example that I've heard before from somebody who we both know is Eric Mara, but he said, finger length can often be seen as like a screen or an attributing factor for like a disease like Marfan syndrome, right? But you don't necessarily go around like chopping people's fingers to shorter lengths to make sure that their risk decreases for Marfan syndrome. Whereas we often see things like screens within rehab senses as saying, oh, okay, cool, this marker is up or down or, not where we would want it to be or makes us want to think, okay, injury risk may be a problem here. And so we go and try and affect or create change within that variable when that just may be a proxy variable for what the actual underlying value is that we're looking at. But yeah, I always find those sorts of things very interesting.
Yep, exactly.
So a lot of times people might, be familiar with some injury mechanisms when it comes to hamstring injury, but could you give us maybe an explanation as to, on the muscular level or on the muscle tendon unit level, what is occurring when it comes to this kind of acute phase of hamstring injury?
Yeah, that's a great question. I think a lot of times many of us have been led down this path from some of the classic papers from the 90s and the early 2000s to talk about how muscle recovers from an injury. And unfortunately, those classic papers were artificial induced lacerations, right? So they cut these individuals, or they contused they contused them in a way that was a more of a crush type injury mechanism, which is very different than what we see in a sports setting, which is a true strain, right? I mean, the two ends of the muscle where the attachments are, where it attaches either into the aponeurosis and the central tendon of the muscle or more into the proximal free tendon, starts to is under a high tensile load, and they start to separate or pull apart from each other. Um, and so the mechanism is much different, and no surprise, the recovery process is much different. You know, in particular, what we see a lot of is almost the idea, a phrase that was coined many, many years ago, and I had first heard of it during my PhD days back in the late 90s, but the idea of popping sarcomeres. Some of us have probably heard that as being a contributing factor to delayed onset muscle soreness, right? That's really what it was this phenomenon where the myosin heads and the connections to the actin, they slipped essentially the opposite direction and resulted in the sarcomere rapidly changing its length in a longer direction and resulting essentially it pops, right? And then now it's got to remodel and produce new ones. And that's probably one of our best ideas as to what's happening during these strain injuries is we think at least that there's some of these popping sarcomeres essentially that fail and then have to be regenerated and potentially even add additional sarcomeres to their length during part of that recovery process. The idea that a longer fiber or fascicle might be advantageous and potentially even reduce injury risk is an active area of study. There's some great investigators in Australia that I've worked quite a bit with over the years. David Opar and his group, you know, Ryan Timmons and Matthew Bourne and Jack Hickey and a number of others who have done quite a lot of nice work in that space.
That's awesome, and especially when we kind of dive into some of the more, structural underpinnings of the muscle itself. Are there ways that we know how to kind of meaningfully alter or change those sorts of characteristics? I'm thinking things like pennation angle or sarcomere length, things like you had just mentioned. Or can we meaningfully change those when it comes to our exercise selection or our kind of quote unquote prehabilitation exercises that we try to aim to prevent these injuries?
Yeah, that's a great question. That is exactly what we try to do, right? Is through our injury prevention strategies, mitigation strategies, recovery strategies, is to influence some of that structural piece. At the sarcomere level, I would say no, we probably can't change the sarcomere length. That tends to be fairly fixed, at least to my knowledge, unless something new has been discovered. But it's not an area that I'm actively up on. But um, what we do know is we can change, or we believe we can change at least the length of the fascicles by what we think is adding additional sarcomeres to it. Although again, that's there's not great data to rule out one or the other as to exactly how that happens. But you know, the work that Ryan Timmons has done, probably the most work, at least in terms of ultrasound imaging, as it relates to the hamstring with different loading profiles, and in particular, eccentric load, right? And not just a little bit of eccentric load, but it needs to be fairly high levels of load. And then particularly the positioning of the muscles, ideally at longer lengths. But again, there's even some back and forth as to what lengths are required for this and when you do or don't observe it. But really, the big piece that we've seen is this higher load intensity requirement, ideally under eccentric. Some groups have shown it under isometric as well. That would result in a increase in length of these fascicles. And in general, anywhere from half a centimeter up to a centimeter, maybe even a centimeter and a half, that can occur after as few as a handful of weeks, 3, 4 weeks maybe. you would start to see some of these changes happen as soon as under this sort of loading progression. So um, what we're starting to see more of is, do we see these changes across all the hamstring muscles with a particular type of exercise, or are certain exercises more specific or targeted to either the lateral muscles of the hamstring versus the medial muscles of the hamstring? Um, Most oftentimes, the biceps femoris is what's studied most commonly because it's the most commonly injured muscle of the hamstring. And we haven't seen a lot of work yet that's looked at imaging of all three major biarticular portions of the hamstring as it relates to each one of the muscles. Our Typically what we've seen is the EMG, or muscle activation profiling, is done to try to drive exercise selection as much as anything, and then using best understanding of load progression within that, and then also range of motion or positioning within that exercise that we know to recruit a particular muscle.
It's really interesting. Where my head goes a lot of times is kind of trying to understand, the dose response kind of process when it comes to different training loads, and then therefore either subsequent recovery or detraining, and then returning back to sport and playing. Similar to, having an off season, maybe you take a week or so off, and then you get back into kind of preseason training with the team and those sorts of things. What kind of changes do we know occur within those phases, or what happens within that when we're looking at certain structural adaptations with the hamstrings, and what could be some of the negative effects associated with training and or detraining when we look at the hamstring?
Yeah, you bring up an excellent point. I'm also oftentimes surprised how people don't necessarily factor that detraining aspect in to all of this work that they just put in on the training side of it. So the downside of the detraining piece is, well, I'll start with the plus side. The good news is that within a week or two, you generally don't lose strength, or change cross-sectional area that much. That tends to hold itself pretty well. The downside of the bad news is that those architectural properties that we just talked about do tend to change quite quickly. As little as 7 to 10 days, certainly as many as 2 to 3 weeks, you can result that fascicle length change that we just talked about, that half a centimeter to 1.5 centimeters of increased length, will essentially disappear within that amount of time. So the general advice that we give is you want to at least expose that muscle to a large eccentric dose on a weekly basis to try to preserve those architectural changes as best we can. Everybody needs a break. We understand that breaks are in for other reasons. And we're not suggesting that you need to do your maximum training efforts every single time during that period of break. Uh, but it is good to at least do a couple of things within that period. If that fascicle length is one of those coveted areas that you tried to work to get during the training period, and especially if you have a history of muscle tendon injury that you need to try to have a higher, or a maintenance program, if you will, to really make sure that those are addressed heading into a period of high training loads. We see this quite often in American football, um, or in many other sports as well. But that's the area that we spend a lot of time looking at is, before you head into fall camp, right? Before August 1st, many programs are taking a week off or even longer. At the professional level, it's typically a couple of weeks. And so a lot of that gain that has happened during OTAs or during, off-season conditioning work, to really try to build up this resilience, if you will, against muscle tendon injury. There's potentially a really important aspect of that resilience that has been lost during that period of break.
Yeah, I couldn't agree more. When you're talking about kind of these sort of top up doses within different off training weeks and those sorts of things, the the idea of just having a little bit of an eccentric dose within a week to week kind of variation is probably going to be helpful. Do we know if the kind of, I guess, speed, for lack of a better word, of that eccentric dose matters? Like, does it need to be a fast eccentric? Can it be slow? Can it be an isometric at a long muscle length? What do we know about that, or what do we, I guess, suspect about those sorts of options?
Yeah, that's a good question. I think what we know the most about is the typical um, resistance exercise dose. So whether that's isometric or whether that's an eccentric dose during a classic sort of exercise maneuver. And so with those, we'll see the fiber length changes, and we'll also be able to show that you can preserve the fiber length changes with a certain amount. The argument I think could be, well, is a couple of doses of sprinting, is that enough to preserve it? And that's a really good question. I think the jury's still out on that. I've not seen good data at the architectural level to show what running alone will do or won't do. My my gut says it's not enough. Even though the loads are quite high, I don't think it's enough to preserve the architectural changes. Because many times we see in individuals who are doing a lot of heavy or high speed running still have shorter fascicles. And it's not until they begin to dose with higher intensity eccentric exercises where we begin to see some of these architectural changes. But again, I am happy to be proven wrong on that. If we have some good sprint related changes in architecture, I'm all for it. If we can preserve it in as many ways as possible.
I love that. Is there, I guess, transitioning a little bit more away from the more like myopic view of structure and kind of expanding out towards, a little bit more of the functional side of things. When we have these screening measures or methods of assessment, most often people immediately will think about, peak force, like how strong is the hamstring? Um,
Mm.
Beyond, we can touch on peak force as well, but beyond peak force, what other qualities do you feel like would be important to look at in a kind of hamstring screening and or rehab, and how would you go about measuring those qualities?
Yeah, so I mean, our current screening study, meaning what we're doing is we're taking a whole lot of measurements on five different NCAA football programs at preseason, and then looking to see which ones help to predict who goes on to sustain a hamstring injury during the subsequent season, as well as then which ones develop a re-injury pattern, as that we can factor in as well. I I guess what I would say is that knowing what we know now, I would not put all my eggs into one risk factor basket, right? Which is what unfortunately is kind of the direction that we've gone in the recent years is saying, all right, I'm going to look at this one thing and I'm going to do it. And it makes sense because you're talking about massive screening, right? I mean, most football programs in college are 120 athletes. And so imagine trying to do a rigorous screening tool or assessment on that many players. It's certainly daunting, and time always factors into what approaches you end up using, right? What's feasible, what's palatable by the players. um, so I mean, ideally what we'd look at is some aspect of their training. We'd look at some aspect of their running mechanics. We would look at strength. We would look at some aspect of their range of motion, if they have, just egregiously restricted motion or flexibility issues. And then, of course, all their players' history as well. That'd be phenomenal, right? If we could capture snapshots on all of those, and that's ultimately what we're doing, in addition to an MRI assessment of structure, right? Do we see changes at the muscle level and the morphology level that actually allow us to identify those at risk? Our idea is not to say that everybody needs to look at all of this. That's what we're doing as part of the research, right? Our goal is that we can titrate this down to three or four or five key risk factors. Prior injury, of course, is going to be in that mix. And my guess is that to some extent, running mechanics will play a role as well. May not be the driving factor ultimately that we say, okay, we need to look at joint level mechanics on everybody. Potentially not. That would be too challenging. Hopefully, there's some bigger picture, more global things that we can look at. But then I think strength will play a role in that mix to some extent, but probably as an interaction with other metrics, right? Not a standalone by itself. From a neuromuscular standpoint, one thing that we do look at, we do a Nordic hamstring screening on all of our players. We measure multiple times a year. And a few years ago, we published a paper that supports several other larger papers done recently to show that your peak force on eccentrics during a Nordic curl, for example, Nordic hamstring exercise, doesn't identify injury risk. But yet, on the N of one that I'm seeing in clinic, I'm absolutely going to look for that and say, all right, number one, do you have a reasonable amount of strength? Two, we're starting to get more sports specific and even position specific values that we expect to see. So are they reaching those? And then three, what does their force time profile look like during the task? Not just the peak, but how are they getting to the peak? Is the impulse where we expect it to be? In terms of that how the force develops over time. Are they shifting from one side to the other? Are they plateauing too early? There's a lot of elements that we need to dig a little bit deeper than just peak force.
It's a great topic that you kind of just touched on. I remember I had seen a webinar that you'd done recently where you kind of touched on this idea that I hadn't really heard about too much when it came to the Nordic hamstring exercise and assessing it through like Nordboard, where, like you mentioned, that sort of plateauing
Yeah.
of that forced time trace. Can you kind of unpack why that would kind of, raise your eyebrows or make you want to look a little bit deeper?
Well, I think what ends up happening a lot of, at least where my mind goes when I see this plateau, is that the athlete is not doing the exercise quite as well as we would like them to do. They're either not going as far down, holding that neutral hip and pelvis position. They're stopping short in that position. Maybe they're getting to 40 degrees from the horizontal or 35 degrees from the horizontal, when in reality we want them as far as we can get them, down to 20 degrees or less if possible. And or they might be getting to that 30-degree position, and then they start to pitch their trunk. So now they start to bend at their pelvis or bend at their hips, and so that can theory can create a little bit of a plateauing effect in the force time tracing versus if they were to continue down toward 20 degrees, we'd expect to see a little bit more of an abrupt peak.
It's interesting. Is just the way you kind of explain that. Have you played around, whether it was N of one within the clinic or from a research side of things, with performing any kind of razor curls and just kind of understanding how maybe proximal and distal sequencing or changes there would influence more or less like your guiding principles within hamstring rehab?
Yeah, I mean, we played around with the razor curl a little bit. We tend not to use it that much in terms of like an alternative to the Nordic because the loads obviously are quite different. What I tend to do in people who kind of show this particular pattern, or even earlier before, but ideally before they begin to show this pattern, is use an assistive band around their arms or under their arms, under their axilla, and to let them have a little bit of unloading to that bilateral exercise, but allow them to get farther through the motion. I would rather compromise just a touch of that load and increase that range of motion an extra 20 degrees or so, letting them get farther to the horizontal. Again, the goal, I'm not making it easy on them. I'm not using an assistive band to make it easy for them. It's to make it a little bit more on just a little bit rather a bit of unloading to allow them to get further motion, because that further motion is going to jack up that load quite a bit even with the presence of the band. So the smallest band possible that allows that extra load or that extra motion rather, being that if I'm really going after these fascicle length changes and recruitment, I really want that length to be part of this exercise process. The other thing we've done as well is even incorporating NMES into the equation as well. We think of that so often. We go, oh, Post-op quad, yes, of course I'm going to use NMES. Hamstring, why would I ever use NMES, right? It's like, and it's still the same concept, right? We've got issue with muscle recruitment and making sure that there are recruiting, and even more so recruiting the biceps femoris long head as much as possible, making sure that's engaged. And so we want to make sure that we're not biasing one side or the other, or avoiding, as we oftentimes do see. And that's, again, not just a Nordic specific exercise. We might do it with the glute ham raise. We might do it with 45-degree hip extension loads. All have very good benefits from a hamstring recovery perspective.
From your experience, or maybe even just from what you can think about in terms of other people's experiences and where they're at. Let's say you don't have access to something like a Nord board or something that can simply and easily measure eccentric hamstring strength. Where would you first go when it comes to trying to create either proxy measurements or use things like handheld dynamometry that tend to be more accessible for clinicians? Where would you go in terms of assessment strategies to kind of identify different force deficits or other sort of characteristics associated with hamstring strength?
Yeah, I mean, there's nothing really fancy about a Nord board, right? I mean, it's a couple load cells on each side, and that's it. So, you've already referenced Eric, and I know Eric and Scott Morrison love the Tindec and its utility for quad. I think that has potential applications here. You got to be creative. You got to MacGyver it up. But I think you could certainly begin to pull some of those similar measures up just on one leg. Potentially, but I mean, I think that would allow you to pull it, some measurements in it. The other one that I would look at is like on our assessment tool following a hamstring strain injury. This is a paper we published back in Journal of Athletic Training in 2022. I think it was 22. Jack Hickey was lead author on it, but the we make a pitch to at least use handheld dynamometry in a couple of different isometric positions. That's all fine and good when you're dealing with an injured muscle, right? Where you don't expect really heavy levels of force. But if you're dealing with an adult-sized athlete who is, in pretty darn good physical shape overall, and you're looking to prevent injury or assess are they have adequate strength, you're gonna have a tough time resisting them. But or for either of these positions to be that helpful in making a case. I mean, honestly, if they showed weakness in one of those positions, holy cow, you got a problem, because that's going to be a major issue. But to identify those who are more in that gray area, outside of using some level of instrumented assessment, I think we're a little limited in that space. I think we have to use some creative tools that are out there now to try to jerry rig something up, other than if we don't have a Nord board that's available.
It's great. You're kind of reading my mind, bringing up the paper from the Athletic Training Journal. But within that paper, you kind of talked a lot about these kind of ideas of the guiding principles within, hamstring rehab. Can you just kind of walk us through what some of those guiding principles really are? And then understand maybe how those principles are specifically applied within maybe a case or something like that.
Yeah, sure, happy to. Yeah, I'm glad you used the term guiding principles, because that was our kind of our push to this. We did not want to create a protocol, right? And that, because that only works in a handful of individuals to a T, right? But if you have the guiding principles, now you're able to apply that to so many other scenarios and presentations. I think the biggest pieces that we had, in terms of the rehab approach to rehab, first, principle number one, I guess I would probably say that pain is okay, right? Historically, a lot of the early stuff talked about pain-free exercise in these individuals, and that's being unnecessarily cautious. That doesn't mean we don't want to respect pain and acknowledge it and listen to it, but we're also not going to completely avoid it. So 2 out of 3, 10, so a patient level of comfort, individual patient tolerance is what we're kind of going for. Number one. Number two, On the exercise selection, we actually have kind of what we call we've created a bit of a 3x3 grid or matrix. Um, one one progression is about intensity or level. So we have like level 1, 2, and 3, or stage 1, 2, and 3, which is really about what if you do early in the rehab process toward later in the rehab process. How do we progress the difficulty of the exercise? But I think the other big principle is that the other, and applies to that 3x3 matrix, is that beyond just the intensity progression, we're also making sure that we always have three types of exercises that are part of the rehab process. And that is, we do eccentric knee flexion, or knee flexors rather. We do a long hip dominant exercise, and then we do a short hip dominant exercise. And so that's really getting at that the axis of rotation is at the hip. Long and short refers to what the position of the knee is in. So is the knee straight? Now you've got a longer hamstring. If the knee is bent, you've got a shorter hamstring. And our rehab process, we want to make sure that we're including all three of those types of exercises as we progress from early rehab to late rehab. They don't have to progress in the same time frame. One may be farther behind than the others, but that's okay. We want to progress them again, not based on pain avoidance, but by what the athlete can do, and progress them as soon as we possibly can. The other piece that's embedded in that a little bit is manipulating range of motion is just as important in that 3x3 grid. So we may start an exercise with a high load and restricted motion, and then gradually increase that range of motion, keeping that intensity or that load high. That's absolutely part of that progression as well.
I think that last point is very interesting too, because I feel like oftentimes we bias the ability to complete a task in a full range of motion for added benefit a lot of times, right? And that is very fair. Something that a topic I tend to get really nerding out in is the calf, and I think
Yep.
oftentimes we see that very specifically where once you get past neutral and get into plantar flexion, your ability to produce force just drastically drops, and so at some point we probably don't even want to be able to go through a full range of motion and load things heavy enough so that you can't, because we want to make sure that there's adequate load going to those sorts of areas. And I think it's similar, and I love how you guys brought that up in the paper, where you can keep the intensity and the load high and just either manage the range of motion or bias certain positions so that you can still get the adaptations that you're looking for. And I thought that was great.
Yeah, no, it's exactly it. I love your analogy with the calf, 100%. And I mean, even when we think about tendon adaptation, I mean, when we talk about hamstring and calf injuries as being so much muscular, but shoot, we all know there's a big tendon component, right? An aponeurotic component that's oftentimes involved. Depending on what your MRI shows, it may even be like half of the injuries or more have some level of a tendinous tissue involvement. So, what we've learned in tendinopathy rehab, and thinking that through in terms of, yeah, load is really critical. Even if we don't go through full motion, we've got to get load to stimulate that remodeling process, is much more critical than avoidance of load, waiting for full motion to happen. That would be by far the worst scenario in terms of your timeline of recovery.
Most definitely. Um, so often I think this conversation is really circled around the hamstring itself, right? Makes sense.
Mhm.
However, oftentimes like we've got, I don't know, probably 35, 40 other muscles that attach to the pelvis. And that can also probably affect running mechanics and can affect other things. Are there any kind of, we would call them accessory muscles, call them other prime movers. Are there any other either benchmarks or methods of assessment that you look at when it comes to other muscles associated with the lower extremity when you're looking at in hamstring rehab?
Yeah, no, it's a great question. I mean, so I think for part of the process as to what other muscles we look at, do we screen for all the other muscles you just mentioned that attach to the pelvis? No. I mean, that'd be phenomenal if we did. Although I should say that we are screening in some ways So as part of the study, we are doing MRIs of the entire lower extremity. And so we are capturing muscle volume and size of every single muscle with our partner Springbok Analytics, who has software that allows us to be done in rapid time. I mean, less than, 8 minute acquisition and another handful of minutes to process. And you've got a pretty powerful data set afterwards. Um, but outside of the MR's cat space, if we were to look at muscle strength assessment, direct strength assessment in terms of dynamometry or similarly, the ones that I would pay attention to just because of proximity and functional overlap are the adductors, right? We definitely want to take a look at those, especially if you're dealing with a semimembranosus injury, a hamstring strain injury. Take a look at the adductors. Um, The other ones are if the athlete has a history of surgical intervention, whether that's knee surgery, even if it's something you think of as it's a minor partial meniscectomy, right? A couple weeks they're back. Take a look at the quads. Make sure that they have fully recovered, that you're not dealing with something lingering. I've seen this quite a bit in those who've had recurrent hammy injuries over and over and over again, and you look back through their history, and no surprise, there's a bit of a surgery or two that weren't really discussed that often, but they absolutely show deficits that are related to those that probably paint a full picture as to why these hamstring injuries are happening. The other one that I look at a lot from a flexibility standpoint, and I hate the term flexibility because people automatically think of like end range, but tissue tension, let's say it for that, for lack of a better phrase, um, hip flexors, iliopsoas, rectus femoris to some extent, but definitely iliopsoas, and where they start to develop, that low back ache that happens after a lot of running, or they get into that big pelvic tilt position as a result. That is another muscle group that I tend to pay a lot of attention to. Some of our more recent work is showing, back to this idea of after surgery and some of the longer term deficits. We have a paper hopefully coming out in AJSM here shortly that shows many years after ACL reconstruction, we expect the quads to be a bit smaller, assuming you had either a quad or bone patellar tendon bone graft that was part of the procedure. Um, and as well as the hamstring, you expect if they take that graft, that hamstring has shrunk in size. It's not recovering. It's going to be small, semitendinosus gracilis. But uniquely, the gastrocs, medial and lateral head, are quite small after surgery. 2, 3, 4, 5, 6 years out. Even though these individuals are fully back to sport, within, that usually a 10 to 12 month period post-operatively, their gastroc stays quite small. So that's another one that we want to be thinking of in terms of how does that relate to hamstring load? Does that create more of a load on the hamstring, even though they're active at different phases of the gait cycle historically? But there could be an argument to be made there.
That's awesome. That paper you're talking about sounds really interesting. Did you guys look at soleus as well, or was it only gastroc?
We did. The soleus is actually clean. In fact,
Really?
soleus is actually hypertrophied a little bit.
Okay,
Yep.
that was a small hypothesis that I had, but I was curious about it. I just wanted to know selfishly.
Yeah.
Awesome. Well, Brian, I really appreciate your time. This has been awesome. Just to kind of learn more from you and hopefully give the readers or the listeners some kind of tangible takeaways from this. Um, when it comes to just kind of all the things that you guys have going on within Wisconsin, within your own ventures and all those sorts of things, what can the listeners kind of do to get more information from you or learn more about what you're doing?
Yeah, thanks. Yeah, you can certainly follow us on LinkedIn, at UW Badger Athletic Performance. So that's, yeah, an easy one to follow. Any of our recent papers we always put up there right off the bat, or at least give you a snap of what's coming down the line. But also if you know, we've Eric Mira, as you mentioned, has rubbed off on me, and so I actually have a bit of content up on his platform. So at thesciencept.com, if you're interested in running related injuries, including hammy injuries, I've got a couple of hours on hamstring as well as a number of other injuries, including bone stress injuries and whatnot. How to examine running mechanics, with and without technology, depending on what sort of scenario you're in. That's all available up on the sciencept.com platform.
Awesome. And then any sort of, if people want to reach out directly to you, any ways of contacting?
Yeah, yeah. Send me an email. It's probably the easiest way to do it, and it's easy. I'm at an academic institution, so you can find my email online. You go to the University of Wisconsin or at wisc.edu. Otherwise, it's just my last name. Good luck spelling it, but HeiderScheit at wisc.edu.
Awesome. Bryan, thank you so much for the time. I really appreciate it.
Dylan, thank you for the invitation. Thanks for the conversation. Great questions. And thanks for taking your time and effort to put out content like this. This is always helpful.
Awesome. Thank you.